I'm Dr. Libia Scheller, and I'm the Medical Director at the Institute of Medical Education and Research. We are reporting to you live from the 2010 American Society of Clinical Oncology here in Chicago. And I'm so pleased to have Dr. Axel Grothey, who's the Professor of Oncology at the Mayo Clinic College of Medicine from Rochester, Minnesota. So thank you so much, Axel, for being here. You know, it's interesting with bevacizumab, not only in colorectal, but this whole issue of maintenance therapy is coming up as a theory through all other tumor types. And can you comment actually on how you think it works from a microscopic level, where you give chemotherapy first and then give Avastin? What's happening there? What do you think that maybe instead of giving it all at once, and maybe that sequential is better? And then the whole issue of how long is the other question.
It's an interesting point. Again, this is all not validated yet in phase 3 data, but you know, the hypothesis behind prolonged VEGF inhibition is that we actually not target the tumor, but more the tumor-host interaction. We're targeting a biologically and genetically stable system, the host. And the idea of that the tumor constantly try to promote angiogenesis by using VEGF, I think that's a very well-established hypothesis. So tumors would do that for a prolonged period of time and eventually develop other mechanisms to promote angiogenesis by looking at PDGF expression, FGF expression, etc. But it might pay off to keep a level of anti-VEGF therapy around and then block other factors that the tumor might produce in order to promote angiogenesis. So I think the idea of long-term VEGF inhibition using drugs like bevacizumab, potentially oral kinase inhibitors eventually, is a very interesting hypothesis, and which leads into trial designs in ovarian cancer. For instance, we saw some intriguing data here in the plenary session with bevacizumab long term. And trial designs like the Spanish trial I just mentioned. I personally believe this is not ready for prime time in colon cancer, so no one should use, let's say, single agent bevacizumab and maintenance therapy. But I think bevacizumab in combination with the fluoropyrimidine, capecitabine, infusion of 5-FU, this is what we do in clinical practice.
We still have a lot of unanswered questions in the area of metastatic setting as well. Were there any other trials in colorectal that were of interest here at ASCO?
I mean, you know, we see an emergent flow of data now establishing the role of EGF receptor antibodies, like panitumab, for instance, which kind of was the second comer, you know, in terms of cetuximab had its stake claimed earlier. We see actually quite well-designed trials, now phase 3 trials in first-line, second-line therapy, with a lot of translational components around, quality of life assessment, skin toxicity assessments coming from panitumab. And I think in the end of the day, we'll see that both antibodies, EGF receptor antibodies, cetuximab, panitumab, will be on par, more or less, in terms of outcomes. And it's more or less up to your personal preference what people would use. So there's actually several interesting analyses, and I talked to Dr. Dillard earlier today, who actually is going to present some of the data tomorrow in a poster discussion session, that we always talk about skin rash as a prognostic factor.
Right. And
we have very strong data, I mean, accumulation of a lot of database that if patients develop a strong skin rash, outcome is better on treatment with cetuximab and panitumab. So the interesting point is that even patients who have KRAS mutated tumors, when they develop a skin rash on panitumab in these trials, the panitumab trials, they have better outcome, although the drug cannot work. So we know the KRAS mutant tumors will never benefit from panitumab, but patients have a rash, even KRAS mutant tumors do better. And it shows us that the rash tells us more about the patient than about the tumor-drug interaction. It's a different type of patient, a patient that can react to the drug with a rash is probably more able to have immune system stimulated, inflammatory response to whatever. And so this is a different group of patients.
Can you comment on the newer agents that you see on the horizon for colorectal cancer?
So we'll actually see some of the agents presented here. There's going to be a poster discussion presentation tomorrow about everolimus, which is an mTOR inhibitor in a phase 2. Some intriguing data, you know, and not definitive, of course. Then yesterday we saw a poster on a Plexicon drug, which is PLX, or it's a BRAF inhibitor, which is actually interesting because BRAF mutations are associated with very poor prognosis in patients. I mean, we really see half the overall survival that we normally see in patients who have a BRAF mutation tumor compared to non-BRAF mutation. So these patients are in desperate need for novel agents. There's a drug that specifically inhibits the BRAF mutation and BRAF activity, but the data so far in a kind of a salvage therapy setting have only seen few responses, clearly not definitive. On the other hand, there is sign of activity. There is another agent that is being presented here, actually tomorrow, which is perifocin, an AKT/PI3 kinase inhibitor, which has been around for quite some time. And they already presented data from a randomized salvage therapy trial, capecitabine plus minus perifocin at ASCO GI, which were quite intriguing in terms of delaying tumor progression. And this drug is actually in a registration strategy right now. There's another drug called regorafenib, which is a drug developed by Bayer, which is also the registration trial is ongoing right now. The United States will open this trial too. In a salvage therapy setting, patients at need.
And what's the target for that?
The target it's actually a VEGF receptor, PDGFR, platelet-derived growth factor receptor, and TIE2 inhibitor. It's actually one of the only drugs that combines kind of TIE2, angiopoietin, and VEGF system inhibition. And there's some preliminary phase 2 data that led to the phase 3 trial, which will be conducting a 2-to-1 randomization against placebo, overall survival endpoint, so we'll see. So then I think there are a lot of drugs which will come about in the future, MEK inhibitors, for instance. The challenge will actually more be to find rational combinations of targeted agents, because you can easily see that, for instance, blocking one pathway might not be enough, and the drug might be inactive. But instead of discarding this drug completely and not developing it further, it might actually be interesting to combine it with a kind of another agent where you kind of block two pathways. Each of these drugs might not work by themselves, but in combination it might.
Right.
For instance, just give you PARP inhibitors are also interesting for colon cancer. It's not only breast cancer, but we have a lot of agents that actually target DNA, alkylate DNA, or interfere with DNA replication. And these agents might have to be revisited now that we can effectively inhibit the DNA repair system that tumor cells might have.
Right. So in the area of oncology, it's good to see in colorectal cancer that we still continue to have newer agents being developed, and that's always good for the patients. So,
of course.
And clinical trials. So thank you so much. I think this has been very informative to see, the power of the data that you can get from a negative trial, to see that we still have to have some understanding on what's going on in the adjuvant setting, and also that in the metastatic colorectal, once the patient has had metastases, to know that there are newer agents on the horizon. So thank you so much.
Thank you.